Hello. Hi, my name is Deborah Cohen, and I am your MAVEN volunteer moderator for today. Thank you all for joining us and our friends at Health Point Midway Clinic in Washington State for hosting today's session, Dementia, Evaluation and Treatment, with Dr. Richard Mesher. Dr. Mesher is a retired general neurologist who practiced for 32 years with Group Health Cooperative in Western Washington and had an interest in movement disorders. For part of that time, he was chief of neurology and was actively engaged in clinical research. After working for Group Health, Dr. Mesher practiced general neurology at Virginia Mason Medical Center in Seattle, teaching internal medicine residents and medical students. Welcome, Dr. Mesher, and you can begin.
Okay, thank you for that nice introduction, and thank everyone for attending this session. I'm a MAVEN volunteer, have been so since I retired pretty much. And part of that is giving talks like this. So I hope you find this helpful. We're going to talk about dementia today, the evaluation of patients who may have dementia, and hopefully also towards the end of the talk, I'm going to give you some brand new information that has just come out, been published, so you will feel up to date on this topic. I have no disclosures to make, and we've already gone over the accreditation. You can get Category 1 credit for this. So the objectives of this talk include diagnosing dementia, the clinical diagnosis, and also what testing is available. I'm going to focus a lot on Alzheimer's disease since it's the by far and away the most common cause of dementia. And as we talk about that, I'm going to talk about the symptomatic treatments, but also some brand new treatment which may actually affect the course of the disease. This is something we've never had before, and I want you to be aware of it because I'm sure you will get questions about this from family members and patients who may be dealing with early Alzheimer's disease issues. So to begin, let's just talk a little bit about cognition and the different domains that are in the cognitive sphere. These include executive functions such as planning and multitasking. This is mainly in the frontal lobes. Memory, which is located in the medial temporal lobes, specifically a structure called the hippocampus, which is where we make our new memories. Language is usually in the left hemisphere and right-handed in most people. Lefties it can obviously be on the other side, and some people it's bilateral, but most people it's in the left hemisphere. And then visual spatial functions are in the occipital parietal area. So this is just a drawing that shows that the inner aspect of the temporal lobe is where the memory structures, the hippocampus, lie. So what exactly is dementia? Well, those cognitive domains I just mentioned, it means that you have impairment in more than one of them, not just one. So, for instance, if you're just having memory trouble, but that's the only problem you're having, that does not yet meet the clinical definition of dementia. Dementia also has to interfere with your ability to function, either at work or socially. It represents decline from a previous level. It's not a static process, such as from a head injury. And it's not explained by other medical conditions that can cause delirium, which is an acute mental status change. And it's not also caused by major psychiatric illness, such as psychosis. There's this concept It's called mild cognitive impairment, or MCI. It's cognitive decline in one domain, but the patient can still function pretty well. Uh, and they don't have other domains involved. Most typically, this is in short-term memory function. So the patient presents with difficulties forming new memories, but they can still drive a car, they can do other things in their life. And these people, the ones with memory trouble, we refer to this as amnestic MCI. And they have a very high rate of conversion to Alzheimer's disease at a rate of 15% per year. So amnestic MCI is probably early Alzheimer's disease. But just so you're aware of this terminology, it's used a lot. So the primary dementias, I'm not going to talk about Lewy body disease or Parkinson's dementia or frontotemporal dementia. We're going to talk mainly about Alzheimer's disease, but also vascular dementia is a cause in many patients, and many patients have actually mixed cause, both vascular and Alzheimer's. So that's something to keep in mind. I'm going to amplify on this in a little while. So Alzheimer's disease, we're all familiar with it. We probably know someone. We've had patients with it. It's very common. It's sort of startling, but after age 90, there's a 50% prevalence. And it's the commonest neurodegenerative and dementing disease. What are the risk factors? Well, as I just mentioned, age. The older you get, the higher your risk. As I also mentioned, having amnestic mild cognitive impairment will eventually lead to Alzheimer's disease. There's also a genetic factor here. It's a protein called ApoE. A certain allele of ApoE makes you very likely or much more likely to get Alzheimer's if you have both alleles, and that's the ApoE4 allele. Having a family history, especially in young onset, can be a very high risk factor, and there are clearly Mendelian genetic forms of Alzheimer's that are generally young onset, i.e. before age 65. Now, again, vascular disease is a known risk factor, interestingly, for Alzheimer's. So these are some pictures of the brain. On the left, you can see that bluish area, the pathologic changes occur in the inner aspect of the temporal lobes where memory is formed. Eventually, the pathology spreads to other areas of the brain atrophies, the hippocampi, the temporal lobes atrophy, the ventricles get bigger in the severe end-stage Alzheimer's disease on the right. So how do these people present? Well, I think most of you know this, but I'll just say it, that typically a spouse or a child brings the patient into clinic and says that his or her memory is failing. And the patient often either doesn't have insight or really isn't concerned about it, and they usually don't report it. There are exceptions. And so typically it's someone else that points out the short-term memory trouble. So again, short-term memory and loss of orientation are the earliest symptoms. The disease declines progressively and smoothly. It doesn't have an acute onset. There aren't abrupt changes. And after the memory problem is present for a year or two or three, other domains become involved. As you know, Alzheimer's patients have psychiatric manifestations. They can have depression and anxiety either during the disease or even premorbidly. They can become irritable, hard to manage, hostile. They can become delusional, have hallucinations, trouble sleeping. Sundowning, of course, is when the patient becomes more confused and agitated at night. So, in summary, the history is really critical. And it's really critical to interview an informant, a family member, about the rate of onset, the smoothness, make sure they're not having some other acute new neurologic problem. And then you ask about, what's the trouble? Are they repeating themselves? Are they forgetting their keys? Are they misplacing their purse or their wallet all the time? You just have to inquire about some of these other features. And really importantly, you have to say, how is this affecting the person's ability to function? And if they say, well, he or she can't balance the checkbook anymore, he or she has gotten into 3 fender benders, these are huge red flags that, of course, you're dealing with dementia, probably Alzheimer's disease. So you want to look at their medical problems. Have they had strokes? Have they had head traumas? They had other CNS diseases, severe CNS disease. Turns out educational background is somewhat relevant. Patients with higher educational background tend to compensate better for their deficits. Is there a real clear family history in first-degree relatives, particularly with young onset? Has the patient been abusing alcohol or drugs? And then a common theme I'm going to keep mentioning is medications, particularly in an older person. Is there a new medication in the picture that could be affecting them? The point of all this, of course, is to look for things we can modify or reverse and help the patient's cognition. I'm not going to dwell on this rather busy slide. I apologize, but again, I think we are looking for treatable or reversible or modifiable conditions when the elderly patient presents with what appears to be dementia. So it's good to see if they have a focal neurologic deficit. Do they have a hemiparesis? Are they having a really abnormal gait that's changed dramatically? This can indicate potentially treatable problems such as brain tumors or the entity of normal pressure hydrocephalus, which I won't discuss in detail, but that's a whole topic in and of itself. But that presents typically with a very marked change in the gait and urinary incontinence. The cognitive part is not the biggest presenting part of normal pressure hydrocephalus. It's the gait and the urinary incontinence. So what do you do to screen someone cognitively? Well, probably the most widely used test is the Montreal Cognitive Assessment, or MoCA. I'll show you that in a minute. But I want you, if you're not aware of this other screening test called a mini-cog, it's very quick and remarkably sensitive. And so in the older person who's coming in and you have some concerns or the family has some concerns, it's worth just doing this quickly. It's remembering 3 words and having them draw a clock. I'll show you the draw a clock test in a minute. So this is the MoCA. You've probably all seen it. Unfortunately, it takes 10 to 15 minutes to do it. Sometimes staff can learn how to do it. Motivated medical assistants in our clinic used to administer these all the time, saved a lot of time for the physician. It's really probably the gold standard of clinical screening assessments for cognitive decline. In the mini cog, I mentioned this draw a clock test. This is a really easy, fast thing to do. You draw a clock, you put a dot in the middle of the clock, and you say to the patient, fill in the numbers. and then make the clock say 2:30. And as you can see, even in MCI, early Alzheimer's disease, the numbers don't end up in the right place and the hands aren't done properly. And all of a sudden you realize what you're dealing with here. You can have the patient come back for a full MoCA test and try to be more sure about this, but this is a great, fast way to screen patients for dementia. So what's the differential diagnosis? Unfortunately, most of the time in the typical history with onset of short-term memory problems, we do not find these things. We don't find subdurals or frontal brain tumors or normal pressure hydrocephalus. We do screen for thyroid disease, B12 deficiency. Sleep apnea is very important to think about in an older person with cognitive decline, as is severe depression, anxiety, and I mentioned alcoholism or drug abuse. You're all familiar with this. Medications, again, really important to review the med list if someone has recently had a decline in their cognitive function. Benzodiazepines, opioids, anticholinergics, such as people take for bladder issues, old-fashioned tricyclics, even Benadryl can cause some worsening of cognition in frail people. Neuroleptics, dopaminergics, any sedative hypnotics, these all can lead to a cognitive decline. So review the med list for sure. What do? You've done your bedside testing. You're concerned the patient has dementia. They score 21 on their MoCA. What do you do about this? I think in the typical older, greater than 65 population with a typical slow onset, gradual progression, memory is the first symptom, memory loss is the first symptoms. You can do the blood work to look for B12 and thyroid disease and a brain imaging study. An MRI is more sensitive for vascular disease, might reveal some subtle abnormalities, but a CT, if that's all you can do or the patient can't afford an MRI, you're going to exclude big structural lesions, and that's what you need to do. Neuropsychological testing is lengthy procedure, takes hours and hours, it's expensive, it's tedious for the patient. It's not typically needed in the older population with a typical clinical picture. Young onset, rapid onset, for sure, it can be very helpful. Now, there's some expensive specialized tests out there I just want you to be aware of. There's a test called a PET scan, a positron emission tomography scan, that can really pick up this abnormal protein in the brain associated with Alzheimer's called amyloid. It's available. It's not part of the usual evaluation, at least not yet. And then in a little while, I'm going to tell you about some brand new blood tests for Alzheimer's disease. This is really quite revolutionary. So just want to mention that for younger patients, or when the onset of the cognitive change is very rapid or atypical, you're going to have to do other workup. You certainly might get a neurologist involved. They may need a PET scan. They may need a lumbar puncture in that population where the history is not typical, or if they're very young onset dementia. So, why do we need to diagnose the cause of dementia? Well, occasionally we find a treatable cause. There is a tumor. There is a chronic subdural hematoma. There is normal pressure hydrocephalus. There are some symptomatic treatments for Alzheimer's disease. They're not very good, but they are out there. And then we have these new drugs, the monoclonal antibodies that have been approved by the FDA. So this is a whole new area of Alzheimer's medicine. It's really potentially going to have huge impact on the healthcare system. I'm going to talk about this in a moment. The other reasons to know is the patients and the families, they want a diagnosis. They want to know what's wrong because they know something's wrong. And it helps them with planning for the care of the patient. Some patients might want to get involved in research efforts and drug studies, et cetera. And also families might want to get involved in support groups. So what can we do? What can primary care providers do to reduce the risk of Alzheimer's in older people? Well, again, a lot of these patients have mixed pathology. When their brains are examined post-mortem, there's both Alzheimer's pathology and vascular pathology. And it's clear that vascular disease in the brain is a risk factor for not only vascular dementia, but also Alzheimer's disease. It's not clear what the connection is, but it's clear that there is a connection. And so managing risk factors for vascular disease can help reduce the risk of developing dementia for sure. And so that's very, very important. I want to emphasize it. Also, there's good evidence that a Mediterranean diet, exercise, and cognitive activities are helpful. Interestingly, the research has shown that cognitive activities that involve social interaction, such as playing bridge or being in book groups, is more effective than doing puzzles on the internet. So encourage your older patients to be involved in social cognitive activities. Treatment of Alzheimer's with symptomatic treatment is not very good. We do not have a memory pill. We can't improve memory right now. You all are probably familiar with the cholinesterase inhibitors, particularly Aricept. They can improve patients' mood a little bit, make them more interactive. They may slow the disease very slightly, although that's controversial. Memantine is another drug that's been out for a while. It may help with some mood stabilization when people are in the middle to end stages, help the caregivers manage them better. Again, really not a great benefit. So we already talked about reviewing the medications. I won't belabor that. Treat depression, anxiety as needed, and sleep apnea as needed. And then the question comes up, what do we do with the Alzheimer's patient who's agitated and difficult to manage? Well, the only FDA-approved antipsychotic medication right now is this one, brexpiprazole, Rexulti. It's very expensive, but it does have an FDA indication for agitation in Alzheimer's patients. All of the other ones are off-label. Quetiapine, for instance, is off-label use. It's widely used. They all have black box warnings about increased risk of stroke and death. So informed consent has to be obtained from the family before you use them, but sometimes they have to be used if the patient's not manageable. And low doses of quetiapine at bedtime, for instance, can often be helpful. Okay, I'm going to shift over to this new treatments for Alzheimer's. Looks like we're okay on time. So the amyloid hypothesis has been around for 25 years. This is not a new theory as to the cause of Alzheimer's, because it's been known for a long time that in neuropathologic specimens, there's this amyloid protein in the brains of patients with Alzheimer's disease that's quite prominent. Alzheimer's pathology also shows this other thing called neurofibrillary tangles. These are basically dead neurons, and their main constituent is a protein which has been labeled tau, T-A-U. So amyloid plaques and tau protein are in the brain and can be measured. Here's a picture. There's the amyloid that's been deposited. There's the dead neuron, the neurofibrillary tangle, which is composed of mainly of this protein called tau, T-A-U. So there are PET scans, positron emission tomography scans that can look for both of these in the brain. So this is an amyloid PET scan. As you can see on the left, the normal brain doesn't have a lot of bright orange, orangish uptake, but on the left, I should say, but on the right, there's a lot of uptake all through the cortex and in the temporal lobes, indicating lots of amyloid deposition in that brain. So what is the amyloid doing? Why is it causing Alzheimer's? This is the theory. There's this precursor protein, amyloid precursor protein. It has some normal functions, and normally it's cleaved by enzymes, and then the amyloid beta is degraded and removed. So this is a cartoon of the amyloid precursor protein, and then it's cleaved by enzymes, and the beta amyloid that's part of the breakdown products is removed and not deposited in the brain. But for some reason, and this isn't known, is it aging? Probably. Is it genetic? Yes, in some cases, but other causes are not understood. The brain loses its ability to remove this amyloid beta, and it gets deposited in these plaques. And the plaques are thought to be toxic to neurons, leading to neuronal death and then an atrophied brain and dementia. Here's the cartoon version of the beta amyloid plaque. And so it's thought to be toxic. Over the years, people have tried to get rid of this amyloid in the brain. There have been vaccination trials where they vaccinated people against amyloid. Other drugs have been tried, but it's only been very recently that the drug trials have turned modestly positive, showing modest benefit. But I have to point out there's a lot of experts in this field that still don't believe this amyloid hypothesis and think that there's many other mechanisms that could be causing Alzheimer's disease beyond amyloid deposition. And as such, interestingly, I ran across this, but of the current clinical trials, 25% involve anti-amyloid drugs, but 75% of the trials are different drugs looking at different targets or mechanisms, such as neuroinflammation or neuroprotection. So maybe this is more than one cause. But there are amyloid skeptics out there for sure. So these drugs that are now FDA approved, they're monoclonal antibodies, like many other drugs we use these days. They target the amyloid. The amyloid is then removed by the immune system, and they are very effective in getting rid of the amyloid. The PET scans post-treatment are essentially normal in many people. And the goal of this is you get rid of the amyloid and either arrest or slow the progression of cell death and dementia. As I mentioned, multiple older trials with this mechanism didn't work, but they weren't using monoclonal antibodies. So there's 3 of them out. The top one I won't dwell on. It's going to be pulled from the market soon. The bottom 2, lecanemab and donanemab, do show some modest but real slowing of cognitive decline at 18 months. The data is perhaps a little more compelling. So also, very recently, there's been some 3-year data on lecanemab, which shows persistent benefit, even at 3 years. So what are the pros and cons of these anti-amyloid therapies? Well, this is really the first potential treatment that may slow the progression of Alzheimer's disease. Pretty startling, actually, when you think about it. The cons are it's expensive, of course, and these have to be given by infusion, Q2 or Q4 weeks. Donanemab is Q4 weeks. Lecanemab is Q2. And then there's the side effects. The side effects are not trivial. There's this thing called ARIA, amyloid-related imaging abnormalities. And these are either edema or hemorrhage. And in this MRI picture I have there, you can see the edema in the temporal lobes. So as the monoclonal antibodies are causing the immune response to amyloid, edema forms. That's that whitish area in the MRI you see. Most of these reactions are not serious. The drugs can be held and then restarted, but a few of them result in significant symptomatic hemorrhage or edema. And then the other question is, how long does this work? Does this really help over a 5 to 10 year time frame? And of course, we don't know. As I mentioned, there is some data at 3 years, which is a little reassuring in my mind. So where is this being done? Well, mainly it's being done in academic centers across the country. It's being done in memory clinics or dementia clinics by people that really subspecialize in this field. This was some data from earlier this year, how many people were being infused at the UW at Harborview. There were only 8 patients yet being infused. I think that number is quite a bit higher now. Some other places like Wash U in St. Louis and University of Alabama, they were in last spring doing quite a few patients. But the limitation is the demand for this is really going up. The wait time in specialty dementia clinics is very long in many cases. Insurance may not cover this for some people. Medicare does cover it, but commercial insurance may not. So it's really unclear to me how this whole process is going to be managed going forward, because the patients have to be evaluated. They have to have the right clinical situation. They have to have early disease, early dementia or MCI. They have to not have some other potential problems making them at risk for the complications. And it's going to be a slow process trying to gear up the healthcare system to deal with this. Now, this is another topic I wanted to bring up lastly, and this is really new information. There now are blood tests for those 2 entities I mentioned, beta amyloid and tau protein. And these blood tests appear to be as accurate as spinal fluid testing or PET scans. So now we have the potential to have confirmatory evidence that a patient has Alzheimer's through simple blood tests. This paper that I have listed was from Sweden. They looked at 1,200 patients with memory impairment. Some of these patients were evaluated and diagnosed in primary care, and some of them in specialty care. The blood tests for beta amyloid and tau protein had a 91% accuracy compared to amyloid PET and cognitive testing as the gold standard. So this is opening up a whole new set of questions. When do you order blood tests? How do you interpret them? And this is really in a state of flux right now. Certainly, if a patient comes in and says, I'm doing fine, I don't have any memory problem, but I want to know if I have abnormalities on my blood tests, that's not someone you want to test, because people can have amyloid in their brain years, if not decades, before they develop symptoms. So it's not a screening tool. I think eventually it's going to be used when the cognitive testing and the clinical picture really suggests strongly that the patient has Alzheimer's disease and you want to confirm it. But eventually, are we going to start screening people to find out if they're really at risk? Do they have a high level of amyloid in their brain, yet no symptoms yet? So this is yet to be determined, but I think the future may hold something like this, particularly since now we have these treatments. And I'm sure there will be studies coming out in the coming years where patients are selected, they're identified at being at risk by having this blood work, and then they're put on a protocol to get the anti-amyloid drugs. So stay tuned. This is really a field that's rapidly evolving. Okay, that's all I had to say. I'm certainly happy to take any questions.
Thank you, Dr. Mesher, for that very clear and well-presented session on dementia. That was wonderful. The first question we have is from Dr. Fred Kleinsinger. For people in their 70s or 80s, is there a reliable way to differentiate ordinary aging memory loss versus amnestic MCI?
That's a great question, and I think it can be very, very tough if you're dealing with the perhaps earliest onset of MCI. What's the difference between that and just regular old aging trouble? I would say some clinical things to rely on is forgetting names, or forgetting or trying to come up with the right word, but then being able to do it is part of aging. And I think those are less worrisome than if the patient is really repeating themselves, asking the family members the same questions, confusing dates a lot, losing their keys. So I would rely a lot on the history from the family. But I think if the patient comes in and says, I just can't find the right word to say a lot of the time, or I can't remember names anymore, not so worrisome.
Okay, thank you. Another question, would you stop anticholinesterase inhibitor after a period of time if it seems ineffective?
I personally wouldn't hesitate to do that. I think if somebody is in the middle stages of Alzheimer's disease and you want to simplify their drug regimen, you could stop it. I think the chances of causing problems from doing that are absolutely minimal.
Okay. Another question, could you say more about managing psychiatric symptoms in Alzheimer's disease, specifically for agitation and challenges with sleep?
Well, I think, behavioral types of management are the best. I think that if the patient's agitation can be helped by distracting them with an activity, by calling a loved one on the phone and having a conversation, those kinds of things. If you can counsel the caregivers to do that, I think the experienced caregivers that do this a lot, they come up with little tricks like that to try to help distract the patients. Having said that, it can be a real problem, obviously. And I think that the antipsychotics, although this is sort of controversial, I do think there's a role for them, particularly for the patients who get agitated at night and have trouble going to sleep. I think a low dose of quetiapine is a perfectly appropriate thing after giving the family informed consent about the black box warning. Um, Depression, can be treated with the newer antidepressants at low dose. They also can help the anxiety component. So I wouldn't hesitate to use drugs like escitalopram in low doses to help with those symptoms.
Okay, thank you. Another question, is there a longer list of clinics that do the antibody treatment, or is it just those 3 on the slide?
No, there's certainly more than that. I chose them because they were in the article about the experience to date. I do know for a fact in Seattle, um, it's Harborview. I think the University of Washington has the most experience, but I know that they also are administering them at the Swedish Neuroscience. Um, because I talked to a former colleague there, and she told me they were doing it. It's really going to be at a center though. And anywhere around the country, academic centers or large neurologic clinics would potentially administer these drugs. It's not going to be in the general neurology clinic. You're going to have to find neurologists who call themselves behavioral neurologists or dementia specialists. That's what's going to be required, at least right now.
Okay, while we're waiting for further questions, I have one. Is hearing loss a reliable indicator that loss of sense of smell, is that also a sign that someone may have Alzheimer's?
Well, that's a great question. And loss of smell is associated not only with Alzheimer's, but with Parkinson's disease, sometimes years or even decades before the onset of the other symptoms. The problem with this loss of sense of smell is, as you all know, there are lots of reasons why people lose their sense of smell. There's nasal polyps, there's sinus disease, even history of head injury can cause loss of smell. So it's a pretty inexact symptom to hang your hat on. And it's kind of interesting to say to a patient who has dementia is, did you lose your smell 5 years ago? And they say, yeah, I did. I can't smell anything. It's kind of interesting, but is it being clinically all that helpful? Probably not.
Okay, thank you. Question, many older patients are taking drugs such as gabapentin and Lyrica for neuropathic pain, but these drugs are known to result in brain fog with some forgetfulness and occasional confusion. Have you found that to be the case? And if so, how do you advise patients about these side effects?
I think for sure those GABAergic drugs, the two mentioned, can have cognitive side effects. So what I would advise is the question is, are they doing any good? And if someone's been on one for a long time, either gabapentin or Lyrica, pregabalin, you might try, and there is the setting of some cognitive decline or cognitive complaints. You might try to lower the dose as a first step, just gradually lower the dose. See if their pain flares up, and who knows, maybe it won't. And maybe the side effect will be helped, and maybe you can even get them off. So there's no reason, I think, to be leery of trying to taper those kinds of drugs in patients who have been on them for a long time. It's worth trying.
Okay. And is ApoE positivity still a relative contraindication to amyloid monoclonal antibody treatment due to higher risk of ARIA?
It's my understanding it is. ApoE4 homozygotes they are definitely at higher risk. Now, are people being treated? I think probably. Um, but it would be you'd have to give them a lot of informed consent and they'd have to accept the risk. But definitely those individuals have a higher rate of the edema and hemorrhaging. Don't forget, amyloid is also deposited in cerebral blood vessels. And there is a condition called amyloid angiopathy in the brain. Some of you may have heard of this. It causes hemorrhages spontaneously. So people who have a lot of amyloid in their arteries, and then you give them anti-amyloid treatment, they're very much prone to having hemorrhage. So yeah, that ApoE4 homozygote is a relatively contraindication. I'm at this point, as far as I understand it.
Okay. While we're waiting for further questions, I'd just like to remind everybody that in addition to these wonderful educational sessions, MAVEN also offers electronic consultations and also mentoring, both clinical and leadership mentoring. And if any of you are members of different anchor clinics, you can request whatever talks you would like, many of which we're able to do for you. So please keep in mind our three offerings: mentoring, educational sessions, and electronic consults. Any other questions before we give you back a few minutes of your time? You're getting some.
I have
Oh,
one last comment. I mean, I think people are wondering, well, what happens when I start to have memory trouble? Or my parent starts to have memory trouble? What do I do about these anti-amyloid drugs? Is it worth it to take a look? And that's a tough question. I would say if it were me personally, I would go see somebody that uh, is really expert in this, consult them and consider it. Of course, I have the ability to have good insurance and understand the issues, but Alzheimer's is a devastating disease, and if you could ward off the middle stages, end stages by 3 years and have some good quality of life, something to consider, I think.
okay. We do have one more question. Is the amyloid serum testing currently being ordered mostly in specialty clinics or in primary care as well?
It's commercially available. It can be ordered. The question is, what do you do with the results? And it's so brand new, there aren't any guidelines about it. I think personally, if I was in a primary care clinic, I would not order these blood tests without some consultation. I think it's just the whole issue is too complicated. It's so uncertain what the role is for these blood tests yet, although they appear to be quite accurate. So I guess that would be my advice at this point.
And that's a good segue to remind you all that Dr. Mesher is available for consultations through the MAVEN platform. And I'm certain that he would be very willing to answer questions. One last question. What is your approach to discussing stopping driving?
Oh, that's a really, really good question. I think there's lots of data out there that patients with mid-stage Alzheimer's disease, a MoCA test of 20 or 18, their risk of accidents is basically the same as a drunk driver. So I think you have to approach it in a very straightforward way and say to the patient, I'm sorry to tell you this, but your medical situation right now does not allow you to safely drive a car. And it would depend on what state you're in as to whether you're obligated to report this. Some states, I think you are, and where I am in Washington State, you aren't. But uh, I think you really do have data behind it to honestly say to the patient, you really shouldn't be driving. And this, of course, can be very difficult. Patients get angry. They don't want to stop driving. But I think you've got to tell them in a straightforward way that it's just not safe.
Yeah, I think you've touched on a lot of issues which a lot of us are having to deal with or know of people who are having to deal with. Any other questions at all? I don't see any right now, so I think we're going to go ahead and end this session, and please feel free to consult Dr. Mesher and the rest of the MAVEN volunteers as you need us. We're happy to do that. Okay, thank you very much for attending this session, and we'll sign off now.
All right.
Thank you, Richard. That was wonderful.
Oh, good. I hope you found it useful. I hope the other people did too.
I did, and you have a lot of people saying thank you. And also your slides were very easy to read, perfect background and lettering, and just really clear. So thank you so much for that too. Great presentation.
Okay, I appreciate the kind words. Thank you.
Okay, you're welcome. All right, I'm going to
Bye.
sign off now. Mhm.
Okay, bye.
Bye then.